Okay. Good afternoon, ladies and gentlemen. Welcome to the scientific session on cardiogenic shock. I am Seok Kim from Ahram Medical Center, South Korea, and my co-chairperson is Alexandra Lansky from Yale School of Medicine, USA. As you know, cardiogenic shock has a poor prognosis, even if there are lots of progress in the field of medical or surgical device treatment. So I hope this session you may be helpful from many lectures. We have 5 distinguished presenter, and Dr. Lansky and I will chair each lecture one by one. And yeah, Dr. Lansky, please.
Thank you. Thank you very much. I'm going to invite our panelists. I don't know where our panelists went to, but maybe, oh, thank you. Yeah, please come and join us. Oh, wonderful. See, they were hiding. They were hiding in the audience. Thank you. We're counting on you to make this a very lively discussion. All right. Well, as everybody is coming up, I'm going to introduce our very first speaker, David Dudzinski. Did I get that right? Who's going to be talking about the evolution of the CICU and critical care cardiology, which is such an important component of the care of our shock patients. So, David.
Thank you for the introduction. So I'm a critical care cardiologist, and I'm very pleased to be here at TCTAP to talk about a field and a discipline that is evolving and interfaces with many of the techniques and technologies and concerns we have at TCATP. I have no financial disclosures relevant to this talk, but I am involved in local cardiac critical care in Boston, as well as some national initiatives in the United States. In order to contextualize and understand the evolution of this field, we need to go back to the beginning, which is about 60 years ago. And it was the idea of British cardiologist Desmond Julian to co-localize specific patients post-acute myocardial infarction with a specific goal to reduce mortality by monitoring the rhythm and rapidly treating with CPR or with defibrillation. So he brought nurses and delegated that responsibility for defibrillation to the nurses. And at that time, technology in its infancy was used for continuous electrocardiographic monitoring, and that was combined with alarm technology. And in the 1960s, we had this concept proliferate across multiple continents. We had some terms that are common today evolve in the 60s, crash cart, code blue, and whatnot. And this was a model that expanded and proliferated for the next 3 decades in tandem with the treatment paradigms of thrombolysis in STEMI, as well as primary PCI. The evolution of the coronary care unit brought a quality and a process focus to post-acute MI care, as well as rapid defibrillation. And you can see in that top right graph the impact of the revascularization era on cardiac outcomes. But in the last decade of the 20th century, we started to see a different focus in these units. So this is a single center analysis, and it shows rates of admission of STEMI patients less, but we're seeing new problems evolve. Patients with non-cardiac organ failures, sepsis, and we're seeing the need for increased volumes of airway procedures, which are not in the common discipline of a cardiologist. This analysis was repeated in a nationwide focus. This is a Medicare database from the United States showing 10 years of data. And what we see is that coronary artery disease as a primary admission diagnosis declines from 1/3 to 1/5. We have non-cardiac conditions take up the majority of primary diagnoses, and sepsis, in fact, becomes the number 2 most common diagnosis as a primary admitting reason to a cardiac care unit in the United States. So what is the impact of this? So, of course, cardiogenic shock and cardiac arrest drive mortality, but this analysis from the University of Virginia identified acute kidney injury, acute respiratory failure, and sepsis as having profound impacts on in-ICU outcome. And they summarized it with their central illustration: 50 admissions who have none of those, 1 will die. 50 admissions who have any one of those, 11 will die. And so here's where we are in 2025. Cardiac critical care takes care of very complex patients with multi-organ failures, multiple technical challenges, integrating technology and patient. And so how do we keep the patient here at the center and do what's best for them? So we wrote this editorial in JACC to think about who and how would we best staff a unit in the future. And so the theme of this paper was, we're not really talking about a coronary care unit anymore. We are talking about a cardiac intensive care unit, bringing the disciplines from the standard medical intensive care unit and embodying them and infusing them with cardiac principles. We know from other lines of evidence in medical ICUs and surgical ICUs that certain higher intensity of staffing can propel better outcomes, including lower complications, lower mortality, lower length of stay. And the seminal paper in this field was done at Samsung Medical Center. I believe the senior author of this paper is here in our panel today. They looked at 4 years of their CICU data, about 600 patients per year, and the intervention was changing from a general cardiologist to having what they called a cardiac intensivist, who had a broad and deep expertise and were responsible for the entire cardiovascular and intensive care arc of the patient. You can see that the patients over these time periods were relatively matched in terms of age, demographic, Apache score, and then primary admission diagnoses. What this time series analysis showed was that the process metric of implementing a cardiac intensivist reduced mortality overall by about half, and there was a sustained increase over the 3 years after this intervention. You might ask, what drove this intervention? So there were reductions in cardiovascular death in this population, but very importantly, modes of death, including non-cardiovascular and sepsis, were reduced by having this trained and dedicated cardiac intensivist providing the care in the cardiac intensive care unit. So it begs the question then, how do we extrapolate that and define what is required to have this expertise and who should do it? So we've analyzed this question locally and then nationally last year in JACC to try to figure out what characteristics and training are needed. So we would expect the critical care cardiologist, which is the term we use in America now instead of cardiac intensivist, to bring all of the expertise that a cardiologist would. Because we're going to hear later in the session about cardiogenic shock, cardiac arrest, and how to manage those. They need to bring all of that, as well as expertise in valvular disease, pericardial disease, cardiomyopathy, and we want to couple that with expertise in contemporary medical intensive care unit disciplines, managing the ventilator, airway procedures, managing non-cardiac organ failure, in particular liver and kidney, managing renal replacement therapy, expertise in infections, antibiotic stewardship, as well as interventions that we know promote ICU care, like ethics, physical therapy, nutrition. And this physician will also have expertise across a broad procedural palette that will be commonly found in cardiothoracic or cardiovascular surgical intensive care units. How would we train such a person? So in America, our main paradigm is the American Board of Internal Medicine, and the two basic routes would be cardiology fellowship followed by critical care training, or critical care training followed by cardiology fellowship. This method is a little more cumbersome. Not many programs are doing that. It often requires 2 separate matches. About 30 programs in the country have a critical care fellowship that is sort of a super fellowship after cardiology, just like interventional cardiology, just like electrophysiology. And each individual institution is defining its pathway to figure out how it can train its cardiology fellows to become a cardiologist who can achieve certification in critical care medicine. There's quite a debate going on about whether you can achieve that with electives or targeted experiences, but for the most part, the dominant pathway is towards dual boarding. We've taken this at our institution, so we will graduate our 4th fellow in June, and what we've done is tried to bring this cardiology fellow back into a critical care environment with all of the lens and perspective they gain in cardiology. So coming back to the ventilator, coming back to the medical ICU, and focusing on heart-lung interactions, having a breadth and depth of other ICU experiences, as well as dedicated interactions with anesthesiologists, surgeons, and interventional pulmonologists. So in conclusion, the coronary care unit has evolved to the cardiac intensive care unit. It's no longer focused just on ACS. It is a comprehensive, one-stop place where the cardiologist intensivist will take care of all medical and surgical issues for the patient. And in tandem with that, critical care cardiology has evolved as a field with outcomes research, quality research, multinational and multi-center working groups. We are developing professional societies to support this field. There are multiple educational interventions, and then there's a lot of scholarship and discourse about what the training will be with the American Board of Internal Medicine, with the American College of Cardiology, and we look forward to this further evolution. Thank you.
Next lecture is entitled Risk Models in Cardiogenic Shock, What Works, and presented by my co-chairperson, Dr. Alexandra Lansky from Yale. Dr. Lansky, please.
Oops. That was too quick. Okay, thank you very much. That was a great talk. Lots of questions for you, David. So I'm going to talk about various risk models. I think this is a really interesting area. What works? Here's some conflicts. So outcomes, certainly after acute myocardial infarction, where we are sort of in an interventional arena here. So after acute myocardial infarction have dramatically improved over time. AMI cardiogenic shock outcomes have improved, but you can see over the last couple decades have been relatively stagnant, I would say. And I think clearly, I think it stands to reason that as we look at risk prediction, we have to do our risk models based on contemporary data to be relevant, okay? So I think that's point number one. Risk models in cardiogenic shock are incredibly complicated. Why are they complicated? Because these patients are very sick, very complex, heterogeneous patient population, various stages of shock, different degrees of end organ damage and what needs to be measured there for our risk models. The etiologies are diverse, as we just heard about, with, whether it be acute myocardial infarction, structural shock, heart failure, sepsis, et cetera. And each one of those etiologies has different outcomes. And of course, there are multiple measures that we can include in our risk models. And the fourth dimension, which I think is really important and has not really been taken into account, is the dynamic change over time. We know these patients can either improve very quickly within hours or take a downward turn and get much worse. And that typically is not incorporated in our models. You saw a picture similar to this from David, but I think this tells us everything. This is graphically what we're doing when we do these risk models is to try and simplify everything that is going on with our patients into a statistical model to predict outcomes. Right? Certainly not easy. So I'm going to walk you through several risk models that have been done. There are many, I can tell you that. I don't know that anyone uses one risk model specifically. This is from the IABP Shock 2. It looked at 30-day mortality. It identified 6 variables. So age is a consistent one, prior stroke, high blood sugar, high creatinine or acute kidney injury, which chronic kidney disease, which is a common one, lactate level here greater than 5, and this is a post-interventional study, so a TIMI less than 3. And these shock patients with C, D, and E shock patients. You can see that you can risk stratify patients based on these scores very nicely. And in the validation, in the registry, the shock registry, the C statistic was pretty good, 0.79, 0.8 really identifies a very good model. Here's another one, the CARD shock score. It's looking at in-hospital mortality. Here we have 7 variables. Again, you're going to recognize some consistent variables: increased age, confusion at presentation, prior myocardial infarction, a CABG, ACS on presentation, a low EF, lactate levels, and kidney injury. Again, really nice in predicting mortality. And in the C statistic was very good in the development cohort, it always is. But then when you take it out to external validation, it doesn't do so well. And here's another one, and I can go through all these variables, but I think that the recurrent theme here is that in the development data set, these models work very well, but then when you take them out for external validation, they don't perform quite so well. And this is a really nice study that illustrates this point. They identified 70 patients with acute myocardial infarction and tested all of these risk models. And you can see overall, at best, the models or the risk models perform moderately in terms of discriminating outcomes. So not great. The best classification we probably have right now is the SCAI-SHOCK classification. It's intuitive. It classifies our patients based on at-risk, beginning shock, classic, deteriorating, or in extremis. It's something that could be done at the bedside and really helps when we talk about these patients, identifying or understanding where they are, what stage of shock they are. This has been validated in multiple different patient populations in shock, and you can see that it predicts very nicely across the board in every single one of these different studies. There's a gradation of mortality that's very consistent. What's also interesting to see is that there's a lot of variability from study to study. So again, this comes back to the patient population and some of the modifiers that we need to be thinking about when we look at and think about cardiogenic shock. And this is sort of the work that the group is continuing to do in terms of risk prediction. They haven't come up with a specific model, but what they're telling us to do is that you have to take into account shock severity. You have to take into account the risk modifiers, the patient, how frail the patient is, what is the age of the patient, what is the etiology of shock, and the phenotype of shock. So it's really going into that direction of trying to prognosticate and better understand the outcomes of patients. The cardiogenic shock working group is now working on an AI algorithm based on this unsupervised algorithm to identify phenotypes of cardiogenic shock. And I think this is where we need to go in the context of cardiogenic shock, simply because it is so complicated. And in doing this, they have identified 3 cohorts, 3 phenotypes with different mortalities, right? A non-congested, cardiorenal, and cardiometabolic. And again, this is integrating hemodynamics and metabolic derangements to identify different risk strata of patients and different phenotypes of patients. This is a fabulous review on the same topic, and I really urge everyone here to go back and read this, because I think this is where we need to go. And implementing these AI algorithms in a dynamic fashion, taking into account that 4th dimension, whether the patient is deteriorating or improving, really can help, and ultimately I think we'll be able to help in the management of these patients. So takeaways, I think the current risk models are very simplistic. I think it's safe to say that. I think the SCAI-SHOCK classification is very intuitive and should be used when we're assessing our patients. And, finally, the AI algorithms, although this is a very complicated area that's going to take a lot more work, but integrating all the information from the electronic medical record, the MCS outputs, ventilator outputs, et cetera, will hopefully in the near future be able to guide the treatment of our patients and better risk stratify our patients. Thank you.
Next lecture is presented by Dr. Yongwhan Lim from Jeonnam National University Hospital, and the title is New Understanding of Mixed Shock, Complicating Cardiogenic Shock. Dr. Lim, please.
Thanks for your kind introduction for me. My name is Yongwhan Lim, and I'm working as a critical care cardiologist in my hospital. Let me talk about the mixed shock today. I have nothing to disclose about this topic. So let me start from the definition of cardiogenic shock. We all know that the cardiogenic shock is not a single-digit entity. Instead, it is complex clinical syndrome characterized by the hyperfusion caused by impaired cardiac output from the many variable, the primary cardiac insert. Now, we all recognize that there are many diversities in cardiogenic shock in terms of severity, phenotype, etiology, or many things. And in the etiology classification proposed by the Shock Academic Research Consortium, in here, the mixed shock is included in the additional modifiers for the etiology classification. So previously, we also recognized there might be variability in the invasive hemodynamics in patients with classic cardiogenic shock. This is data from the shock trial. It's very famous. There was the observed variation in systemic vascular resistance in patients with classic cardiogenic shock like this. So the concept of mixed shock has been proposed. It's kinds of combined features, the shock with the combined features of both cardiogenic and the vascular shock. It means that there is a depressed cardiac output, but at the same time, there's also inappropriately low systemic vascular resistance. So it is generally called vasodilatric cardiogenic shock, and it is also recognized at high risk and understudied subpopulation of patients with cardiogenic shock. We also recognize that in the epidemiology studies, that this is Mayo data about the analysis of about 2,000 patients of shock encountered in cardiac intensive care unit. The proportion of mixed shock is fairly significant. It is observed in about 20% according to their data, and its prognosis is the worst among all kinds of shock compared to primary or isolated cardiogenic shock or the septic shock. But in-depth review, we could find also that the classification of shock was based on not based on strict invasive hemodynamic assessment. Among patients classified into mixed shock, only 1/3 of patients was diagnosed as mixed shock based on invasive hemodynamic data. And in the method section of the article, I found that the classification was based on the admission diagnosis. So the previously published data about the mixed shock, the mixed shock might be defined with a fairly vague criteria. In the preparation process of this lecture, I searched the literatures about mixed shock in PubMed. Now I found that there have been there was an increase in the published articles, the number of published articles recently. So the recent new understanding of the mixed shock could be obtained by the strict invasive hemodynamic data. For example, this data is from the C16 registry, and they suggest that among about 1,500 patients with the shock assessed by invasive hemodynamic assessment, they found that the significance of systemic vascular resistance, the SVR value is associated with the in-hospital mortality. Another group in the US also showed the detailed features of the invasive hemodynamic profiles of patients with cardiogenic shock. In the analysis, they showed that the higher, patient with a higher SCAI classification has the higher proportion of the proportion of the invasive hemodynamic profile with SVR, lower SVR, lower than the 800. At the same time, although the patient was initially classified into the pure isolated cardiogenic shock, many patients had blunted pressure response. It means that in their definition, low SVR less than the 800 dynes or the inappropriate response to high dose of inotropic or vasopressor agents. They also showed the lactate level is related to blunted pressure response, but not cardiac index is related to the higher lactate level. The patient with lower system vascular resistance or the blunted pressure response were more frequently treated with Impella or VECMO, the advanced mechanical circulatory support. In the survival analysis, patients with the lower SVR or blunted pressure response had a worse clinical outcome. In displaying the curve, they presented patient with cardiogenic shock and the lower system vascular resistance, the lower than 800, showed a higher probability of in-hospital mortality. I'm not sure that the subpopulation of patient, cardiogenic shock patient in this range of system vascular resistance could be referred to isolated or pure cardiogenic shock. Another new understanding recently proposed by some expert groups is that some experts tried to classify patients with mixed shock based on the etiology classification, primary cardiac and secondary insert, which make the vasodilatory hemodynamics. And another group also proposed a similar classification. So during my short experience of the cardiogenic patient, I encountered some patients thought to be having the mixed shock, and I found that it fits well to the kinds of classification. Some patients had a cardiogenic as a primary insert and subsequent vasodilatory deterioration, or vice versa, or it could be also the primary mix. So this is my conclusion. The mixed shock is still very largely unexamined, and the patient group with diversity. And I think that mixed shock should be characterized and diagnosed based on the invasive hemodynamic assessment, although it is very difficult in critical care settings. Recently proposed classification according to the etiology that makes the mixed shock might be very useful to understand this very difficult disease entity. Thanks for your attention.
Thank you very much. That was excellent. So we're going to move on. We'll have a little bit of time at the end to have a discussion. Ahram Kim is going to discuss comparison between cardiac arrest and cardiogenic shock.
Thank you for your kind introduction. I'm Ahram Kim from Assam Medical Center. The topic I will present today is about comparison between cardiac arrest and cardiogenic shock. I have nothing to disclose. Cardiac arrest and cardiogenic shock are among the most lethal manifestations of acute cardiovascular disease, with in-hospital mortality rates exceeding 40% despite contemporary supportive care. While cardiac arrest and cardiogenic shock often occur together because of shared underlying myocardial substrates, their pathophysiological etiologies and sequelae often differ. According to reports, half of patients with cardiogenic shock from AMI experience a cardiac arrest, whereas 2/3 of patients with cardiac arrest have shock requiring vasopressors. Patients with both cardiac arrest and cardiogenic shock are a high-risk group with a mortality risk that substantially exceeds that of patients with cardiogenic shock alone. In one report, patients with STEMI, patients with either cardiogenic shock or cardiac arrest accounted for over 75% of hospital deaths, and subgroups with concomitant cardiogenic shock and cardiac arrest accounted for 1/3 of all hospital deaths. Cardiogenic shock and cardiac arrest often occur together and are therefore frequently confused. However, their characteristics are different. Cardiogenic shock is defined as systemic hyperperfusion and end organ dysfunction resulting from primary impairment of cardiac pump function. The most causes are acute myocardial infarction, myocardial damage like myocarditis, or heart failure. However, the cardiac arrest is resulted from abrupt loss of mechanical cardiac function, typically triggered by arrhythmias, structural heart disease, and ischemia events leading immediate loss of effective circulation. So the hemodynamic profiles are different. Right after the cardiac arrest, the cardiac output is higher and heart rate lower. Mixed venous oxygen saturations can be higher compared to the typical cardiogenic shock. And the cause of shock is different, especially in prolonged cardiac arrest patients. It's not solely due to the cardiac pump failure, rather a consequence of whole body ischemia affecting multiple organs with or without cardiac pump failure. And also the cause of death and prognostic factors are different. In cardiac arrest patients, they mainly die due to anoxic brain damage. However, cardiogenic shock patients die due to refractory shock, multiple organ failure, or life-threatening arrhythmias. And the prognostic factors are mainly determined by the extent of anoxic brain injury in cardiac arrest patients, whereas the cardiogenic shock patients is determined by the initial shock severity, shock etiology, vasopressor demands or end organ function, and LV ejection fractions. So with the cardiovascular therapies, the only treatment that has been proven to reduce mortality for the cardiogenic shock is early corporate vessel revascularization in patients with AMI. And the MCS devices has not been proven to reduce the mortality compared to the optimal medical therapy. In the post-cardiac arrest patients, especially those who are comatose, the treatment strategy must be carefully individualized. In STEMI cases, the early revascularization should not be delayed. However, in other situations with shock, the primary goal should be focused on to minimize the neurological damage, including hemodynamic supports, ventilator support, and targeted temperature management. Due to the differences, we encounter significant challenges when conducting research or interpreting the results on cardiogenic shock trials. If patients with cardiac arrest is included with potential for anoxic brain damage may hinder the benefits of tested cardiogenic shock interventions, may be beneficial in patients without anoxic brain damage. This has been observed in previous negative trials on cardiogenic shock, including recent MCS trials. VA ECMO trials included many cardiac arrest patients, and their result was negative. And on the other hand, the IMPLAS study excluded the comatose patient, and they showed survivor benefits over the medical therapy. In future cardiogenic shock trials, especially when results are negative, careful interpretation will be essential. Moreover, the inclusion of cardiac arrest patients in such studies should be considered with great caution. This is my conclusion. Cardiogenic shock and cardiac arrest frequently occur together, but their characteristics are different. The cause of death in is anoxic brain damage in cardiac arrest, while refractory shock, other organ dysfunction are in cardiogenic shock. We must be cautious in interpreting clinical trials related to cardiogenic shock. Keeping this consideration in mind, we should continue our effort to do the research on cardiac arrest and cardiogenic shock to provide optimal care. Thank you for your listening.
Thank you for a rapid wrap-up. Next presentation will be presented by Dr. Junghoon Yang. He's the president of Korean Cardiogenic Shock Working Group, and the lecture is entitled Revascularization Strategies in Cardiogenic Shock. Dr. Yang, please.
Thank you, Dr. Kim. Firstly, I appreciate Dr. Dudzinski for including my paper regarding cardiac intensivity in your presentation. I'm Jeong-Hoon Yang from Samsung Medical Center. I'd like to talk about revascularization strategy in AMI cardiogenic shock. This is my disclosure. 30% of STEMI without cardiogenic shock, and 60 to 70% of STEMI cardiogenic shock had multiple disease. So optimal revascularization strategy of multiple disease is very important to improve clinical outcome. However, according to the presence of hemodynamic compromise, the current guideline recommend a different revascularization strategy in STEMI with multiple disease. Current guideline recommend ESC guideline, ACCAH guideline recommend that non-corporate region revascularization should be considered before hospital discharge in a STEMI patient without cardiogenic shock. In selected hemodynamically stable STEMI patient and low complexity of multi-base disease, multi-basal PCI may be preferred strategy at the time of primary PCI over staged PCI. The cardiac shock trial is the only one randomized controlled trial to compare clinical outcome between cardiac shock, cardiac-only PCI versus multi-basal PCI in AMI shock patient. In this trial, in the multi-basal PCI group, recanalization of CTO was highly recommended when possible, and complete revascularization was achieved in around 80% of patients. Staged PCI was performed in 18% of patients in the cardiac region-only PCI group. In this trial, the primary endpoint of 30-day mortality and acute kidney injury requiring renal replacement therapy is lower in the cardiac-only PCI group than in multi-basal PCI group. The post-hoc analysis revealed that the clinical outcome was similar in both groups after 30 days. However, the rehospitalization for heart failure and any repeat revascularization at 1 year outcome was higher, paradoxically higher in a complete region PCI group than multi-basal PCI group. Here are the baseline characteristic of cardiac shock trial. As you can see here, around 35% of the study population had less than 2.0 millimole per liter of lactate level. So this result cannot be extrapolated for advanced cardiogenic shock patient, unlike a patient underwent mechanical circulatory support. After the publication of corporate shock trial, recent guideline, ESG guideline, ACCAH guideline, recommend that the primary PCI should be restricted to the implant artery. Immediate multivessel PCI may be justified in the rare case, and staged PCI of non-implant artery should be option after considering and risk-benefit balance. Recent published data using the National Cardiovascular Data Registry from 2009 to 2018. As you can see here, the multivessel PCI was performed around 40%, which increased from 32 in 2010 to 44% in 2017. In hospital mortality in multivessel PCI group was much lower than corporate-based PCI group, but a higher risk of bleeding event and due requirement of dialysis. Among the surviving to discharge, all-cause mortality was similar through 7 years. As you can see here, the clinical benefit of multivessel PCI is pronounced in cardiogenic shock patient underwent mechanical circulatory support. This is a pooled analysis from Rescue Registry. Rescue Registry is a multi-center Korea Cardiogenic Shock Registry and Samsung Medical Center ECMO Registry. In this registry, a total of 408 of cardiogenic shock underwent VA ECMO were included in this analysis. We divide the study population into corporate-only PCI and multivessel PCI group. The primary endpoint was 30-day mortality or acute kidney injury requiring renal replacement therapy and 12 months follow-up mortality. As you can see here, the contrast to the result of corporate shock trial, 30-day mortality or renal replacement therapy in multivessel PCI group is much lower than in the corporate region only PCI. Similarly, the multivessel PCI group was associated with improved 12 months follow mortality. After proposed matched population, this result is consistent. This slide showed the revascularization strategy according to the ischemic territory. As you can see here, the large ischemic territory involvement was associated with worse clinical outcome. This slide showed my perspective on revascularization in AMI shock underwent VA ECMO. It is unclear whether the role of immediate multivessel PCI differed for an extremely advanced form of cardiogenic shock underreported in the corporate shock trial. The clinical role of non-corporate region revascularization may be different from that other MCS device, like impeller device, because VA ECMO may induce pulmonary edema along with increased LV filling pressure. It may result in aggravation of the ischemia in the non-corporate region territory and delay the cardiac recovery, leading to failure of ECMO weaning. So I conducted a randomized control trial named Rescue Shock Trial. This trial conducted by a tertiary center in Korea. The primary endpoint is a 90-day all-cause mortality or advanced heart failure requiring cardiac replacement therapy, such as LVAD or heart transplantation. We will stratify it by large non-implant artery ischemic territory and participating center. Contrast to the corporate shock trial, in this trial, in the case of CTO, or heavy calcified region, revascularization strategy attempt is left in the operator discretion, even in multi-based PCI group. Currently, we enrolled around 240 patients. In summary, corporate shock trial show corporate-only PCI was associated with a low short-term mortality compared with multi-based PCI. In current guideline, immediate multi-based PCI may be justified in the late case. Rescue registry and Samsung Medical Center ECMO registry showed that benefit of multi-based PCI in patients who undergoing VA ECMO, particularly the carpal region with large ischemic territory. Rescue shock trial, a randomized control trial, is ongoing to identify the optimal revascularization strategy for AMI cardiogenic shock patients who are undergoing VA ECMO. Thank you for your attention.
So thank you very much. Don't go very far because it would be wonderful to have some discussion on revascularization. I'm going to kick this off and try and get the panel engaged. I'm going to start with the very first lecture that we heard from David on the training of the CICU members. So my question to David is, do you know in the US the proportion of CICUs where there is an intensivist leading the CICU?
Thanks, Dr. Lansky. It's a phenomenal question. This field of critical care cardiology is in desperate need of more national organization and data collection. What we know is that from multiple sources of data, there are about 180 critical care cardiologists currently dual board certified by the American Board of Internal Medicine. Many of those work at approximately 30 institutions, but there's marked heterogeneity. For example, my institution has 6. NYU has 13, I believe. Many other institutions have 1 or 2. But short of that, there's not been a clear phenotyping and registration of all the units and all the practitioners therein. It also depends on how you define the unit. For example, one of the analyses from Sean Van Diepen suggested there were 600 CICUs in America. And so we really need to stratify by what's evolving as a classification level 3, level 2, level 1. What we're really talking about here are the level 1 CICUs. No agreed upon number at present.
Yeah, and it sounds like they're clustering. So you know, the pedigrees sort of cluster at one institution. So at our institution, I think the switch was made 2 or 3 years ago. So, you know, 3 years and back, the interventional cardiologists, general cardiologists were the ones leading the CICU. And I was impressed by the data you were showing where there was actually a mortality benefit, right? So talk about a treatment effect. Didn't you show like a 50%
Yes.
reduction in mortality?
Dr.
That's
Yang's
impressive. So let me ask our panelists here. In your institutions, do you have intensivists? Is the cardiologist, the interventional cardiologist? Who's leading the CICU? Maybe I'll start. I'm sorry, I don't know everybody's names, but maybe we'll go down, starting with you.
Yes. My name is Mijoo Kim from Chungnam National University. I'm a cardiac intensivist, work in CICU. I have a question for Dudzinski. Cardiac intensivists are becoming more important, but we don't have a formal training program in our country. What do you think an ideal training program for cardiac intensivists?
So this is another area of intense debate. And in America, the main pathway is critical care medicine, a second full fellowship of 1 year following a full cardiology fellowship. The counter argument is that it's eliminating some people who would like to do that because it's time intensive. In particular, the effects on women of childbearing age. So a woman who's in her 20s or 30s has to decide to take more time. Also, because the training is prolonged, people of different socioeconomic strata may not have access. There are multiple lines of discussion about how you could train a cardiologist short of that. Should there be electives during general cardiology? Should there be certain experiences, certain certificates, micro-credentials? all of these are being discussed in America right now with no clear consensus. So I don't want to postulate how it might apply to another country.
So it sounds to me like this is fertile ground for a consensus, and it's maybe an international consensus. David, I think you should be leading that.
Thank you. We tried in America last year in that JACC expert panel to lay out what we thought was the appropriate vision for America, and despite having representation from 23 institutions, we still found marked heterogeneity from the authors represented and other institutions as well. So.
Anybody else from the panel who wants to comment?
Yes, can I have a question also for this topic? Well, I was impressed that you showed that the pure cardiac causes who are admitted to the CICU are decreasing, while those who have kidney failure, hepatic failure, or septic shock are increasing. That's what we are feeling in our center also. So regarding that, what my question is, although that I am also a cardiac intensivist, the people who we need to lead the CICU, are they critical care medicines who have slight knowledge for cardiology, or should it be the other way around? Because we are treating, let's say, STEMI so good that we don't have patients dying for STEMI, but we have hepatic failure patients who have non-STEMI who are dying due to hepatic failure. So who do we need?
This is also an excellent resource utilization question. In America, we have a shortage of pulmonary critical care intensivists. So for our profession to grow, if we were to take physicians away from the pulmonary and the MICU units, that from a social and an overall national organization point of view may engender other adverse consequences. So I think it's incumbent on us as cardiologists to get that knowledge. And I myself, if I have a patient with a very advanced non-cardiac organ failure that I can't manage, I will certainly, so if I have interstitial lung disease in a cardiac patient that's becoming the primary issue, I will decide I may need consultation. But for us, in general, we don't have enough pulmonary intensivists who then want to do cardiology. And then the question would be, how much training would they need? So one potential model that's been floated is do 3 years of critical care medicine with pulmonary and then 3 more years of cardiology. And that 6-year program seems unpalatable.
So, another thing to talk about here is we talk about shock teams. And I wonder, in the context of, what you're defining, David, as a dedicated CICU intensivist, I wonder if that kind of, supersedes the need for shock teams. Shock teams are actually quite difficult to put into place. So at least that's what we've experienced at our institution, just to coordinate everybody and get everybody sort of on the same page. So I wonder if we can have a little bit of a conversation about that. Is the ICU leader the main focal person to direct and oversee the care of the patient and determine when that patient needs to go to the cath lab, when that patient needs to be escalated on mechanical circulatory support, etc. So just some comments on that topic.
For myself, we actually have those 2 roles closely unified at my hospital. So I think to your question, Dr. Lansky, and it ties in very closely with your lecturer, the critical care cardiologist is helping to quarterback that team, coordinating with cardiac surgery, with the cath lab to decide to, number one, recognize early when a patient is having cardiogenic shock deterioration. The trajectory that you emphasized is so important, and having the iterative evaluation by the critical care cardiologist who's in the unit is very important to assessing that trajectory. Now, maybe AI will supersede that, but so that's a very important role. Device selection, patient selection are also very important roles. Patient selection is very important to make sure there are no relative contraindications and to help us foresee what the course may be. As Dr. Yang said, we really need to think about what the type of device. Do we need an unloading or do we need higher support? So I think that is really important. And we also at my institution have the critical care cardiologist who's taking 24/7 call. These are the people who are receiving calls from referral hospitals, so we can help them assess on an early basis what their patient may need. That we also take calls and consults from the emergency room in particular, but also the floors, because we see complications from under-recognition of hypoperfusion and early incipient cardiogenic shock. We see harms from the treatment of hypotension and tachycardia with, for example, beta blockers and crystalloid. And by having us take those referrals in-house, we can prevent some iatrogenic harm, help recognize shock, and help deploy MCS. So in fact, if anything, our shock team has grown more robust for both in-unit and referral basis by having the critical care cardiology team at the center.
How do you activate the shock team in your hospital via text message and electromedical record telephone?
Yeah, it's been years of evolution, Dr. Yang. So what we had multiple different iterations, but for about the last 5 years, we have one page number that goes to the surgeon on call, as well as the person who's carrying that cardiac critical care pager. And because that attending is in-house 24/7, they can immediately respond at the bedside.
Okay, I'll keep going with my questions. I mean, I think there are so many here. So shock protocols. I mean, I think it's really difficult to put in place a protocol. What we've done very well, I think, in the context of STEMI to define, door-to balloon times, et cetera, and all these metrics that we have implemented. And I wonder, one of the, I think the reasons why we see such high mortality or the delays to treatment is the under-recognition of shock, escalation of inotropes, et cetera, before we take, further action. So I guess my question to the panel is, can we develop shock protocols that can be implemented within sort of universally across all institutions? We'll start with you, David, since...
Well, we'll give someone else a chance. Go.
It's a great idea to apply to every single center in the universe, but I think it's kind of impossible. Maybe it's a kind of a different system in hospital and country and any reimbursement system. So it's very hard to start. But if you try to start, I will join.
Well, actually, about this, we have a rapid response team in our center, and they're not all doctors. We all have nurses working there, and we wanted to make a checklist to, if we have a patient on the rapid response alarm, the team goes and checks for, let's say, the capillary refill time, how much inotropes the patient's on, how the respiratory rate of the patient. So we want to make it very simple so everybody could do it, and to give as much objective information for somebody not beside the patient to have information, let's say the MICU team. But even that was very difficult because the patients who have any kind of RRS alarm are very heterogeneous. So some people, we don't have to have even the capillary refill time at all. Some people are not on inotrope but still need to come to the ICU. So it was very difficult to make this very simple, even identification protocol for those kinds of patients. So if we want to make a treatment protocol for a heterogeneous disease type like cardiogenic shock, I think that would be much more complex and much more difficult. But if it were possible, it would be very easy, very good, but very good for the patient.
Dr. Kang, in your center, the cardiologists are included in the RRT?
We have turns, and I am also in one of the turns, so yes. It's painful.
Okay, any other comments from the panel on
I'm Dr. Jujo from Japan, and I think that totally different situation in the United States and Japan and Korea also, because in Japan we have tons of a lot of small hospitals, including university hospitals and small tiny hospitals everywhere in Japan. So we actually have a very small amount of human resource. So no, of course, in the specific hospital, university hospital in Tokyo, the special team for cardiogenic shock or including cardiogenic cardiovascular intensivist, but it's very rare. So could you tell me the situation in the hospital or human resources everywhere? What about that Korea, South Korea?
Well, I know that Japan has a lot of small hospitals that do a lot of procedures. Well, let's say small hospitals do 100 TAVIs per year.
Right.
Korea's situation is slightly different because we have large centers and more human resource within a single center, which makes that kind of cardiogenic shock team more available. But even in Korea, it's very difficult because we have to have a team 24/7 to do all these kinds of works. And obviously, it's not one person as a team. So, well, we are slightly better than Japan, but I think that it's difficult for Korea too.
Right, I think so.
Okay, so I think we're coming to the end of our hour, but I did want to have a little bit of a, I don't see anybody, pushing down the doors here, so I think we do have a little bit more time on revascularization. So I was really intrigued by your studies and what you showed, where in patients on ECMO, the outcomes are actually better with full revascularization, a multi-vessel revascularization, which is kind of, in contrast to, traditional teachings where you do culprit, only treatment. So several questions around that. You showed 17% of the patients in culprit shock actually had a stage procedure. And I don't think that culprit shock really intended to say, we only do the culprit lesion, we leave everything behind forever. I think the intention is acutely you do the culprit lesion, but then you go ahead and potentially stage. And with that in mind, the question is, when should we be staging these procedures, right? So multi-vessel disease, you do your culprit lesion, and when would you stage it? When is it safe to do that?
I think the timing of non-culprit lesion revascularization is totally depends on the lesion complexity and the patient complexity. For example, the non-culprit lesion is limb main and limb main os, and the non-complex region, not left main bifurcation. At that time, in my practice, I performed the non-culprit lesion revascularization. But if the non-culprit lesion is chronic total occlusion and or has a heavy calcified region, I don't touch the revascularization at the primary PCI. And next, one must later, when the patient hemodynamically stable, at that time I touch the region like the CTO and heavy calcified region.
Right. So you'll postpone those interventions. And then the other question I had for you was, you in your studies you use VA ECMO. Is that because you don't have Impella? I mean, how do you put that in the context of dangerous shock and the data that has come out that has been positive for those patients?
Yeah, unfortunately, the Impella device is not available in South Korea. Maybe it's available in this autumn, September or October. I tried to introduce the Impella device in Korea.
I have one question to Dr. Yang. I wonder your protocol-based antithrombotic strategy in your study in patient receiving PCI and with ECMO. What is your antithrombotic strategy?
It's a very important question. In current guideline, the current guideline recommend that P2Y12, potent P2Y12 inhibitor, the prasugrel and ticagrelor in the same patient. But in the setting of ECMO, we need to prescribe the anticoagulant like the unfractionated heparin, agatroban. In this situation, the bleeding risk may be high, and patient underwent VA ECMO. So I recommend Plavix clopidogrel in patient underwent VA ECMO.
Time's up, so let's wrap up this session. We really appreciate our panel's speakers and participants, and thank you again. Yeah.